Okay, with that, the last one, and I'll take you through my 25 minutes, the top 10 trials of coronary intervention of 2023. There will be no from 2022, all the latest one. I always start my presentation with the tribute to person Andreas Grundtvig. Because of him, we are here. And the dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patient, which I added on with the utmost safety, the appropriateness, and ambulatory, knowing that 60-65% of cases, we discharge them same day. So idea would be that the steady presentations which have changed our practice in 2023 will be presented. The first one, which is mechanical circulatory support in cardiogenic shock. We have two trials, Euroshock and ECLS shock. So basically, Euroshock was a small trial which was presented compare patient with a cardiogenic shock, do standard therapy or standard therapy plus ECMO. Remember, ECMO has taken a lot of center stage in our post-COVID time and basically showed if you take a 10-day, 20-day, 30 days, and then 1 year follow-up, absolutely no difference in mortality by using the ECMO. These are the individual endpoint, although you can see that there is a little bit lower mortality, but cases were so small, 35, 72 went down to 22% reduction, but no made a p-value. Only problem was higher bleeding and vascular complication. So this is one message. The second, the trial which was just presented and in European Society and published in NEJM, ECLS shock trial, bigger trial, 200 plus in each arm, randomized cardiogenic shock patient to same ECLS versus continue your regular treatment, and basically again showed at 30-day exactly identical, about 50% mortality. These are the numbers. So what did we learn? And higher peripheral vascular complication. So basically ECMO trials in cardiogenic shock failed so far. No true evidence, rather more vascular complication. Second, we have a complex patients. We have definition of complex patients, many of them, starting with our ACCHA, we have the New York State, and many other definition of what we call complex case patient, which called CHIP, complex high risk indicated intervention. And recently, UK BCIS, which is like our ACC NCDR, same organization in UK, they came up with a CHIP score, and then we used that data for Mount Sinai from our database, which, as you know, Dr. Roxana Maran is in charge with a lot of other people. So we said, let's validate that. What was it? This was the UK BCIS CHIP score. They took 7 patient factor, 6 procedural factor, basically common ones: old age, diabetes, female sex, stroke, MI, PAD, low EF, and procedure left main, 3 vessel, need for mechanical support device, long lesion length, rotational atherectomy, and divided patients in no risk, which could be from 0 to 13, and high risk, intermediate, and low risk. And there was a gradient of in-hospital MACI, which is major adverse cardiovascular and cerebral event. So this, we said, we have our database. Let's put this into same score on our Mount Sinai database on 21,000 patients. Individual numbers are here, quite a bit large, kind of in 3 and 4, 20% each. And what we found also the same gradient at 1 year. So 1 month extended to 1 year based on the no risk, 1.7, 3, 6, and 12, multiple. Every time you put them together, and all aspect, death, MI, stroke, death, MI, stroke, TVR, and bleeding. So all aspects of our intervention were associated with bad outcome with the increasing score. So this is a simple, good score. So you say, why do you need it? Well, it basically will triage your patient. You have many of those high risk that patient need to be admitted. Make sure you have the beds. So it cannot be the outpatient. Those patients will be monitored more closely, and a lot of has been said about antiplatelet therapy. These are the high score patients will require definitely long-term antiplatelet therapy, if not short. And this actually has been put into as our scoring, various scores in the PCI have been there. Then drug-coated balloon in small vessels. Finally, drug-coated balloon is in America. In the coronaries, they actually peripheries have been there for 6-7 years. Because of a lot of controversy in the periphery, drug-coated balloon had a higher mortality, so there was big kind of resistance or reluctance from the FDA. But with the data all over the globe, the drug-coated balloons are good. DES is the stent with the drug stage. Drug-coated balloon, only the drug leaves in the artery, a stage in the artery, and balloon comes out. So this has been done many trials out of United States, and now finally has started few of the trials, and Roxana is PI of one of the trials which we have done at Mount Sinai. And these trials, basically the drug with the special nanotechnology, whether you use in the instant restenosis or in the de novo vessel, and all three drugs. It started with the paclitaxel. Now we have the data on the sirolimus. We are part of the sirolimus trial, and everolimus also starting. The benefit of drug-coated balloon are short depth. We are not leaving any metal, no additional metal, no polymer, so probably lower inflammation, and no side branch closure. Many of the stents close the side branch. So those are the potential benefit. And is it truly a benefit? There is one trial done for the small vessel. Now we have the 3-year data showing that particularly in the diabetic patient, compare against the drug-eluting stents. Vessel size 2.5 is small, they call. The TVR, the restenosis, which was 9% basically in the drug-coated balloon, and with the DES was 15%. So it seems to be in the diabetic patients. All the overall event rate in the non-diabetic in this study was not different. And also we learned that if you put a stent with the drug-coated balloon, you use a drug-coated balloon, but now you have to use a stent because there is a dissection, you're not happy. Those have very high event rate. So key is just like brachytherapy. When we do brachytherapy, we don't put any stent. Same way, when you drug-coated balloon, you have to clear with the lesion, good. Then only use a drug-coated balloon, because putting a stent, maybe double drug, cause more trouble. Then there is another paper from Korea, another study that you have a drug-eluting stent, drug-coated balloon strategy. So about 1/3 of them will require stenting. So in those cases, you don't put a drug-coated balloon. So otherwise, with that strategy, you see all cases, the multivessel disease, lower event rate with a drug-coated balloon compared to 13%, went down to 4%. Very remarkable. Again, they are all talking about a small vessel so far. Then there was a trial done called Picoletto, which is the 3-year data now of 2.75, 203 patients. Again, the similar message that lower TLR with a drug-coated balloon compared to, and no thrombosis. So another plus point of drug-coated balloon compared to drug-eluting stent. Then in the STEMI patients, maybe many times you don't know whether patient going to take antiplatelet therapy or so. Can you do it? Not a randomized trial, but basically from the registry showing that using drug-coated paclitaxel balloon versus drug-eluting stent, there was no difference in mortality, acute coronary syndrome, stroke, major bleeding, or TVR. So seems to be that we are going into the myocardial infarction group also, and particularly advantage, you don't have to worry about long-term antiplatelet therapy. So this basically is our working diagram and consensus statement that when you're planning the drug-coated balloon, so far I would still say, based on the data, is small to medium vessel, less than 2.75 millimeter vessel, or maybe a diffuse disease, long up to 30-40 millimeter, because the balloon is up to 40 millimeter in length. So prepare your lesion. Whatever need to be done best, balloon, rotational atherectomy, cutting balloon, and if looks good, angiographically good, you need to see by whether intravascular imaging or by FFR, and so physiologically looks good, then use drug-coated balloon. Otherwise, does not look good, go to the DES. And we learned the data, 1/3 will require DES. What you don't want to do, that you are ready to put a drug-coated balloon, result don't look good, now you put a DES, your event rate goes 4 or 5 times. So now we actually, so far, we have completed the instant restenosis trial of the drug-coated balloon in USA. Now they are starting into the native vessel and side branches, probably in few months, the FDA given the nod to the coronaries, because there has been no issues of the mortality which was otherwise seen. Imaging trials, I know a lot has been said. This year has been the plethora of very many randomized imaging trials. As you know, just to say, angiogram, this is intravascular ultrasound, this is OCT, this is infrared spectroscopy. We have many devices and physiology with the FFR and IFR. All these actually have become part of our interventional armamentarium. We make a decision which case to do, not to do, what to do, and when to and optimize the results. So all those, there are criteria based on various studies, but just to say, we have gone beyond angiogram. And all additional this imaging, intravascular imaging, which we say has helped us to improve our outcomes further. So there are few trials. The first one was in the ACC Renovate Complex PCI, and this is a large trial of 2,100 patients, imaging guided versus angiographic guided PCI with 1 year outcome. In this, 75% IVUS, 25% OCT. So this was left to the operator, whether you use which one you want to use. And actually it is also in United States. We have the ACC NCDR. It overall at present about 22%. I think it has become now 26%, the latest data of imaging done in United States. And ratio is about 3:1. 3 IVUS, 1 OCT. Both are the used, but 3:1, similar to what was in this trial. And what did we find? Imaging guided PCI, which is the blue bar, compared to red, which is the angio guided PCI, was superior. So in complex cases, it was superior using the imaging guided. Then there was a second trial presented now actually in European Society. Ziad Ali, who was our fellow, very expert in this field of imaging. Again, large number of patients, and they have patients who are complex both clinically as well as angiographic, and 2,400 patients. And these were the diabetic, multiple lesions, non-STEMI, calcification, ISR, CTO. These are the complex cases, OCT versus angio-guided. And what happened, few things we saw, and which we expected actually, that anytime you use imaging, you do have some more time, more fluoroscopy, more procedure time, and higher contrast use. So that is known. So acutely, it didn't do that well, but that's okay. That's part of the procedure. So there are two primary endpoints. One was that is how good the stent lumen is. We call minimum stent area by OCT, and what we found that in the trial, OCT has a better lumen compared to angiographic lumen. As you can see, a significant p-value. But that is the only imaging point. But that doesn't matter to us. What matters whether it's going to reflect into the better outcome to the patient. And of course, you can see better protrusion and so. But outcome, 24 months, OCT guided 7.4, angiography guided 8.2. Absolutely no difference in individual endpoints are here. So in terms of the hard endpoint, no difference. But one, you got better stent. Maybe that will translate into a better outcome later. We don't know. But the clear cut was the stent thrombosis was 0.5 versus 1.4%. So that was p-value significant. So this trial, I would say, first one, Renovate, positive. This one is like plus minus, positive and negative both. Then there was a third trial presented that what if we use OCT in bifurcation lesion, which is October trial, OCT guided versus angiographic guided PCI in 1,200 patients. And here, they have actually side branch more than 2.75. The plan was that you are going to take care of both the branches and individual. In this particular case, they have various technical points to see what will happen with the OCT guided versus angiographic guided. Not much different, but in terms of the primary endpoint of the death, target lesion MI and ischemia-driven TVR, is now angiographic guided as 14%, OCT is 10.1% superiority of the OCT guided. So now you imagine one trial in the same time presented day before negative for the long term, and the second trial for the bifurcation was positive with OCT guided having a lower event rate. But overall, in this trial, there was no difference in stent thrombosis. In the earlier Illumin trial was lower stent thrombosis. Then to put things together, of course, Dr. Greg Stone has shown the real-time updated network analysis, also presented as a late-breaking trial, OCT, IVUS, and basically showed that in large number of patients, 11,000 plus, the risk reduction of a target lesion failure is significant in favor of intravascular imaging, which is combined both OCT and IVUS, individual cardiac death, all-cause death, target vessel MI, all MI, and stent thrombosis. I think stent thrombosis is very interesting. Consistently, you see the curve on the left of the unity. So it has to be that almost 50% reduction of stent thrombosis with the imaging. TLR is like 29%, some trials positive, some negative, but that we need to see. But this is basically where we are. Overall, it seems to be that this is something which we're using more and more in our day-to-day practice. Now, the question, these are the individual points which have been shown. Now, in the two, OCT versus IVUS, which one is better? So if you take this from the meta-analysis, and you see here, actually there is not much, but OCT guided, there is a little higher in terms of the TVR in this meta-analysis, but otherwise there is not much difference. So this actually also lead to another very important publication on this imaging with the state of the art, and they actually have gone to show, actually very important by the ACC Interventional Council, the operator institutional and national level to really increase the awareness of imaging during PCI. And this is same as I mentioned, 25%. This number now is 28% in the, because we keep getting running quarter data from the ACC and CDR, and still about 20. Sinai, about 5 years ago, we used to be about 5%. The latest, we are around 21, 22% also now. And useful in all aspects, pre-lesion and assessment. In my opinion, the post is the most important, like 90%. You know, if we see from three aspects of the using imaging, the end is the ultimately what you need. Then at the field of imaging, then we have the late-breaking clinical trial by Anu on yellow 3, Evolucom on coronary plaque characteristics in stable coronary disease. And idea was that patients who have high lipid, as you see the intake criteria on the top, and these patients have baseline OCT based on the lipid core burden, then near an IVUS was done, then patient received 140 milligram of Evolucom every 2 weeks for 26 weeks and came back and had another imaging study in there. And of course, the mRNA analysis, genetic analysis, which is still awaited. What was the basically point was? We say, how does the statin works? Statin works by making your plaque, the membrane, the cap, the plaque cap thick. So basically the minimum fibrous cap thickness, which we call or the thin cap fibroatheroma, less than 65, it became 48% of the baseline, follow-up became 13, plaque became, the cap became thicker, 71 to 97. Now, as Jagat showed earlier, 20% had no effect. Although everyone's, their LDL went down, HDL was slightly, CRP didn't affect, HDL went a few point up, LDL, everyone like 40, but still, 20%, there was no change in the cap thickness. So this is the type of patient we need to see. Maybe those are the one who gets the event later. Then same is the lipid core burden index. The lipid core really decreased significantly. In this also, in 24% of cases, there was no change in lipid. Now you say, why? Well, and it was not related to the LDL. LDL went down in everyone. Many of them, LDL was 1, and still there was no change in LCBI or cap thickness. There is something else there, just to show how it looks. This is the lipid, see at the baseline, almost disappear. And the cap thickness, and a lot more work to be done to understand. And most important is if we can get some genetic marker, which is a part of this yellow 3 study, that which patient do not respond will help us in the future. So this is for the imaging. Then we say, which I briefly alluded, there was a randomized trial to see IVUS or OCT, because you see the proponent of both are there, although IVUS is a little used more because of ease, and you don't give any extra contrast. So for various reasons at present, IVUS is used more than OCT, and there was a trial called Optimus randomized trial, another 2,000 patient, routine PCI, and what was the inclusion exclusion criteria was the same type, which are routine patients who are undergoing intervention, particularly the drug-eluting stent, and follow-up. the total amount of contrast between two. OCT, more contrast, as you can see here. As I said, the dye has to be given more for OCT. There are many agents are being worked out, maybe which are non-iodinated, and you can use them without, don't need for OCT purpose, but that's still investigational. Some people have done with the saline only, but overall OCT required giving dye 2-3 times, sometimes for the imaging and compared to IVUS. But more important was the angiographic based and imaging based procedural success. And procedural success basically was that the successful PCI at the intended target lesion which fulfill the optimal criteria of stent implantation for IVUS or OCT. It seems to be that IVUS guided got a little better job, and any procedural complications that you see here, no difference. So procedure itself, OCT and IVUS, as you see, zero complication. So benign, it takes just time, maybe still a little extra dye in patients with the OCT. Now, what also the analysis found that all stent optimization, that has your stent been fully expanded or optimized the way the trial has defined? It seems to be that IVUS does a little better job compared to OCT, and stent expansion, as you see here again at the bottom, is little better. Now, these are all acute parameter imaging, but that's okay. We learned ILUMEN 4, parameters were good, but there was no difference in the death and MI at follow-up. So what happens basically here? Also, no difference. So you can get a little better lumen, little better stent expansion compared to two of them, but no difference in overall long-term outcome. So, and even individual, only thing is we have found that if you have a more complex cases, syntax, IVUS has a little tendency toward better. So, but key is whether you decide IVUS, OCT, both are equal. That's the final message. This is the 1 year and 2 year outcome. Then our functional complete versus culprit PCI in old patient, the FIRE trial. So you remember the complete versus culprit. There was a complete trial, a patient with STEMI, we do a culprit vessel revascularization or full revascularization, which was stage, majority of the patients, so that immediate as well as stage in the trial. And now we say, what about the older patient? Maybe they don't need the complete revascularization, just do the culprit vessel STEMI, PCI. So this trial, the FIRE trial investigator, in patient more than 75 years of age, both STEMI and non-STEMI, as you can see here, randomized and basically showed the same message which we have with the original complete trial. That is, the death, MI, stroke, and ischemia-driven revascularization was 21% in the culprit only, and physiologically guided complete revascularization went down to 15.7%. So this was done actually the physiologically guided. Death and MI also same message, and you can see here the complete revascularization, if physiologically guided, was better even in elderly patients. So that message became full revascularization. So then second question was, if we say yes, complete revascularization is better, but do you do it at the same time in the same hospital admission, or you can stage it? And you say, well, this is such a simple question. I can tell you 2 major trials this year looked into this aspect, that do you do immediate versus stage complete revascularization. One was the first BioVasc trial, patient again, non-inferiority, about large number of patients, 1,300-1,400, immediate complete revascularization during the index procedure, or you stage them, usually 6 weeks. You know, always our feeling is we do after 4 weeks, as you know, in our common practice. So do a immediate, same hospital admission or same time, or stage it, and basically the 40% were STEMI and 53% were non-STEMI patients, and found that immediate complete revascularization was better compared to stage complete revascularization. So you say why? The 2 middle points, MI and planned revascularization. You say why that happened? We didn't see that signal in the complete trial, but complete trial was only STEMI. This was both STEMI and non-STEMI. So we know that many of these patients with a STEMI, we know there is a higher inflammation. This culprit lesion is very active, maybe 70%, but active. And while they are waiting, patient to come back for repeat PCI, patient had the MI and urgent revascularization, 5%. So therefore, purpose, the message, do it at the same time, or maybe, sometimes you may not do same day, but within the same hospital admission. Now, then other feeling was, maybe by doing it, you have a more bleeding, no difference. There was a data also in terms of higher kidney injury, was no difference in the trial. The second trial also was the same. Timing of the complete revascularization with multivessel PCI for MI, just presented again in European Society, immediate PCI during index procedure or PCI with a stage in 19 to 45 days of the non-culprit. And guess what? Similar message. Stage PCI 16.3% event rate went down half by 8.5, the points just because of the same non-fatal MI unplanned revascularization. So message, you need to do PCI. Now, these were basically done by angiogram, not by FFR, physiology. But key is more than 70% lesion. It makes sense that do it at the same time rather than delaying the stage on that. Left main revascularization, there was some data about the pooled analysis and the EBC. We know this is what part I showed last year, the 4 randomized trial of left main, Syntax, Pre-Combat, Noble, and Excel, 4,400 patient, 5 to 10 year follow-up, basically showed from mortality point of view, you have a penalty of 0.2% per year. In 5 years, 1%, and in 10 years, 2% higher mortality, but not significant. So if you talk about that PCI in all these randomized trials, that no difference in mortality, and of course, there was higher MI and repeat revascularization was much higher with the PCI. So that's the cost, but not the mortality. So this is what the presented. So, but now, of course, more complex the lesion, higher syntax score, cabbage is better than the PCI. So then, similar data from the same 4 randomized trial. Now, what about the difference in acute coronary syndrome? A lot of people believe in acute coronary syndrome, maybe PCI is better compared to, there was slight signal in the earlier analysis. So they took it prospectively that from the, again, pooled analysis, ACS and no ACS, clearly event rates are higher in this left main group with the ACS versus non-ACS, we know that. Now, if you take the whether ACS or non-ACS with the PCI or cabbage, as you can see here, the lowest event rate is in the non-ACS and cabbage, other three are identical. So seems to be basically ACS, PCI or cabbage, you take all the hard endpoint of particularly with the death, no difference, which we learned from the earlier data. So these are the other individual endpoint, which we learned same. So basically message is that even in acute coronary syndrome, patients with the left main, particularly complex disease, will do better from the lower MI and coronary revascularization point of view, but definitely not from the mortality point of view. Then there was the EBC main trial, which was the trial of technique of the left main intervention. And this basically was whether you put 1 stent or 2 stents. They presented the data of the 3-year in the Euro PCR, showing that earlier there was no difference at 1 year. Now it started showing some lower TLR with the stepwise provisional stenting, which was done in about 22% of cases versus 2-stent approach. But we still believe, if you have bifurcation left main, we still go with the 2-stent approach. Then FFR and IFR trials. We have learned quite a bit in this FAME, DEFINE, and so we learn about the FAME trial with the 3-year data presented, which is the FFR guided PCI versus angiography guided cabbage of multi-vessel disease, patient excluding left main, the 750 patient each arm, in FFR guided, FFR less than 0.8, all lesions got the PCI, and cabbage, of course, based on the angiogram. And we learned that 1 year data was clearly in favor of the cabbage versus PCI. And now we have the death, MI, and stroke at 3-year follow-up. The still benefit continues. The superiority of the cabbage in overall this multi-vessel disease, the way done in this trial, including lower repeat revascularization and myocardial infarction. Now, except if you have a lower syntax score, that seems to be the PCI better. So same message is the same. Multi-vessel, low syntax score, PCI better, more complex, go for cabbage. And these are the, now what has happened, just to say, that we have 2 trials, syntax trial and FAME 3. These are the trials of complex PCIs and so that how things have happened, the death MI and stroke, numbers which used to be 14, 15%, 12, death used to be 9 at 5 point, became half. So these are all advancement of the interventional cardiology, which has reduced the complication of intervention and so. So then the defined flare. Briefly, as mentioned, IFR and FFR, two tests, physiological. IFR does not require giving adenosine. We have 1 year follow-up. The only thing is, if you do IFR-guided PCI, the strategy has a lower revascularization compared to FFR-guided PCI. But overall, from the end point of view, 1 year and then the 5-year data showed that initial 1 year data was no different. But now at 5 years, you start seeing little curve separation in favor of FFR than IFR. 21% event rate with the IFR, 18.4, all-cause mortality 9% in the IFR group, 6% in the FFR group. What the reason is, we do not know because individual endpoints, as you can see here, the slightly just favor lower in the FFR, but that translated into a 3% difference in mortality, not known. But this is where we have the data. So clearly, so we at a Sinai, we use IFR only in 15% of cases where patients who cannot take adenosine because of asthma or patient with a valve disease. Otherwise, we believe in FFR all the time, and that is what we use in about 52% of our interventions, FFR guided. So these are the individual mortality. Now, you say, well, maybe it's only one trial. No, so remember IFR, FFR, besides defined flare, there was another trial called Sweetheart. And they actually presented last year. Also, all-cause mortality was 9.4 versus 7.9. Although p-value was not significant, but there is something is happening that IFR-guided strategy has a slightly non-significant or borderline significant mortality at 5-year follow-up. The most important, and I would say maybe as an interventionist, is the disappointing trial, which I have still included again for this year, is revived BCS2 trial. And BCS2 trial basically was the patient with a low ejection fraction, this assessment of the viable myocardium by means, and then complex PCI, undergoing PCI versus medical therapy. So this basically was a trial. And trial basically showed that average about 5 years, 4.5 years, there was no difference in optimal medical therapy versus PCI. Very disappointing. And you can see only difference was unplanned revascularization. Of course, patient to medical therapy, they require PCI. That's okay. That we learn in every trial, courage trial, anything. That those medical therapy group will get PCI, ischemia trial. So that's okay. But as long as there is no harm of the death and MI, which was not in this trial, as you can see here, there was periprocedural MI, which has been consistent, same unplanned revascularization, and spontaneous MI definitely is lower in the PCI group compared to medical therapy group. Softer endpoint. But the main endpoint of the death MI, no difference and so. We say, well, maybe the ejection fraction improved. In these ischemic patients, we all told everybody, viable myocardium, you do PCI, you improve the ejection fraction. And answer is no. So this was we knew about this information last year. Now, in ACC, they presented that let's deep down, because we have so much data on these patients in point of view, in the viability, improved EF, and a subsequent outcome, that let's see individual parameter, maybe we can find some subgroup which PCI benefited or those patients should get PCI. So one was that what we saw, that improvement in the left ventricular recovery, which they defined 4.5% improvement, that happens when you have viable myocardium. Remember, we always have said you have scarred myocardium, you have no improvement. And the dysfunctional viable, they have their definition, but if you have viable myocardium, there is an improvement in left ventricular recovery. That's one point. Second was by viability characteristics. So if a recovery of the LV based on the viability of the myocardium, and you can see here, no difference whether you are viable, dysfunctional, or scar burden. Third, if you take more than 4.7 or less than 4.7% change in ejection fraction, then you definitely have a better outcome. So even in the trial, if you take a patient who got improvement, overall trial, there was no improvement. But if improvement, they have a lower event rate, lower mortality at 5 years if your EF improves. So what learned basically, You do this ischemic myocardium, you did the intervention. If your EF improved, then only you improve the PCI prognosis, otherwise not. So this, they put it together, few points, that PCI does not improve prognosis or LV recovery in ischemic cardiomyopathy compared to medical therapy alone, regardless of the viability characteristics at the baseline. Then scar burden adversely predict prognosis and likelihood. So based on the scar, so that patient will have higher event rate at the follow-up. And the lastly, that abundance of dysfunctional yet viable segment was not associated with prognosis or likelihood of LV recovery. So I can tell you in a nutshell, very confusing trial. I don't think I can give you any message from this. Basically nothing, means all our concepts have been attacked by this theory. Hopefully, when this comes out in paper, we can make some sense of it, that what patient will improve and we follow them. So let's put it together. These are our top 10 interventions of 2023. I always give credit to Dr. Fuster as a central illustration I had to put together for you to take home message, which was the central illustration as a Fuster, the Jack editor. Now every journal, almost every journal now have central illustration. It started by Dr. Fuster 9 years ago. So PCI and LV dysfunction, ischemia, and ECMO in cardiogenic shock. 2 thumbs down. Could be 3 thumbs down even. IFR versus FFR at 5 years, and IVUS versus OCT, plus minus, no difference basically. We actually started seeing IFR maybe slightly worse. Slight data on the inferior to OCT, so plus minus. Then FFR guided PCI versus CABG, our FAME3 trial, PCI versus CABG in left main, in acute coronary syndrome, BCI chip score, I give 1 thumbs up. Imaging guided PCI, although one was the Illumin 4 was the negative, but overall was the good data for all the imaging guided. And then PCSK inhibitor for increasing cap thickness, 2 thumbs up. And drug-coated balloon in small vessel and diabetic, and immediate complete revascularization in both STEMI and elderly patients is, I would say, the change in practice. That is what we learned from multiple trials with a consistent message that do immediate PCI on multi-vessel disease in acute coronary syndrome and complete revascularization, the patients, irrespective of the age, to make us better interventionists and improve our survival. And thank you very much. I'll stop here.